Hi, and welcome. Welcome to my office at MD Anderson. My name is Dan Gombos, and I have the honor of being a professor and chief of ophthalmology at the section of ophthalmology here at MD Anderson in Houston, Texas. And for many, many years, the Cure Ocular Melanoma meeting had focused primarily on uveal melanoma. And a lot of times the term ocular melanoma and uveal melanoma are used alternatively, and it's really not an appropriate terminology. There really are 3 or 4 different places where melanoma can occur in the eye. And the most common area that we often deal with is inside the eye in the uveal tract. And that is called a uveal melanoma. But there are other parts of the eye that can develop melanoma as well. The eyelid skin, for instance, is an area that can develop melanoma. And very rarely you can develop melanoma in your eye socket. We call that orbital melanoma. But another area that often doesn't get a lot of press time at these meetings is conjunctival melanoma. And that's what we're going to talk about today. And you have to think of conjunctival melanoma as a different entity. Yes, it is a melanoma of the eye, but it presents differently. It acts differently, it spreads differently, we do different testing on it. And so today is a little bit of an introduction into that type of melanoma. And of course, this society is all embracing, and we want to include the general ocular melanoma community. And so for many people who have conjunctival melanoma, there really hasn't been an easy opportunity to come to a meeting and fully understand their very rare disease. In fact, in some ways more rare than uveal melanoma. But as we'll talk about, just as important, also has risk for spread, and therefore really should be managed by a group of specialist doctors, ocular oncologists, pathologists who have expertise in this area, medical and surgical oncologists as needed, as I'll speak to in a few minutes. And hopefully we can get away from the term ocular melanoma and be a bit more specific and talk about uveal melanoma or intraocular melanoma, skin melanoma, orbital or eye socket melanoma, and conjunctival melanoma. And these disclosures that are on your screen here, they're really not related to anything that I do with melanoma and of the conjunctiva. And I put them here so you're familiar with them, but these are more related to my relationships with uveal, intraocular melanoma, and other cancers. So just like you've learned with tumors inside the eye, there are various tumors that can occur on the surface of the eye. And some of these are benign. You can develop warty-like lesions on the surface of the eye. You can develop other kinds of cancers, like squamous cancers that you'll often see on the skin or other surface areas. You can develop things that are not cancer at all. So like, for instance, in this picture over here, what you see is a discoloration of the eye and the eyelid. And that's not a cancer. It's a pigmented condition called a nevus avota. Now, that condition predisposes to intraocular cancer, What you see there is not cancer at all. It's, if you like, a big birthmark. But there are cancers that occur on the eye and in the corner of the eye. So the corner of the eye, that area where you wake up in the middle of the night and get some sleep in, if you like, is a very interesting structure. We call that the caruncle. The caruncle is a juxtaposition, if you like, of the skin and the surface of the eye. We call the surface of the eye the conjunctiva. The conjunctiva is a saran wrap sort of layer. And the caruncle is a feature of the eye that has both skin components and conjunctival components. If you look at it carefully, it actually has little hair follicles. And if you look carefully at this picture, you can actually see some hair follicles emanating from this area, but it is part of the conjunctiva. Now, in this area, it's not uncommon to see pigmentation. Sometimes pigmentation can come and go. Sometimes that's related to mascara wear. Sometimes it can be related to use of certain drops. It's not uncommon to see pigmentation in this area in young adolescents. And a common scenario we see is that young adolescents will develop rapid pigmentation in this area. Everyone gets worried. Is that a melanoma? Well, the good news is in most young adolescents and children, when you see a rapid pigmentation there, it more often is not a benign, non-cancerous type of birthmark. But parents get worried, and we often remove it just to be sure. And the nice thing about this area is it heals beautifully. We can cut this area out. It has almost no implications to vision, and cosmetically it looks very great. And we're very often able to take those areas out. So again, in a young adolescent or young child, that's not an uncommon scenario. Now, believe it or not, you can get birthmarks or nevi on the surface of the eye. And both of the areas that I'm showing you here were removed, but were all 100% benign. So just when you see something pigmented, just like in the inside of the eye or on your skin, it may be nothing. And just like we have talked about with the inside of the eye cancer specialists are able to assess these areas and to distinguish things that are more likely or less likely to be cancerous or concerning. So when you come and you show us a pigmented area like this, the first thing we're going to do is we're going to do a very careful exam under the microscope. And the microscopic part of the exam is called the slit lamp exam. And it's basically a big complicated microscope. And we're looking to see if this area is on the surface of the eye, if it's thickened or elevated. If you really look carefully at these pictures, you can see cysts. And in this particular situation, we love to see cysts because cysts suggest to us that the lesion is more likely to be benign. We also sort of look to see if the area is sort of stuck down or mobile, and we like to see things that are mobile. Also, if we have documentation that this area has been there a long time, that's very comforting. And sometimes, not infrequently, we'll just take pictures and tell the patient to come back. And so here again, clinical comfort, clinical expertise is a big component of the care. And not infrequently, we'll take pictures, and those pictures will be helpful in future documentation. Now, we're always telling patients, if you see something new, we can never be 100% certain. And so we're always going to have the option of a biopsy. But if you see something benign and it's been there a long time, it's not unreasonable to watch it and see if it remains stable. So if we see something that we think has all the features of a nevus, the treatment may be watch it. Now, sometimes a patient may still say, I don't like the pigmentation. People ask me about it all the time. Can you please take it off? An experienced surgeon can do that. However, I would always say if you're going to take off a lesion that you think might be benign, make sure the surgeon is using techniques to completely cut out the area and always, always send it to the pathologist. Never assume that something is benign without sending it to a pathologist. If you're going to go through the effort of cutting something out, use techniques with the assumption that it's cancer and use a cancer technique to take that area out properly. And we'll talk about that. Now, there is a predisposition for cancer in the eye called primary acquired melanosis. In short form, we call it PAM. And this is an acquired pigmentation, and it can occur on any part of the conjunctiva. Now, keep in mind the conjunctiva is not just the surface of the eye that you can see on the body of the eyeball, but it's also the area underneath the upper and lower lid. So you can see in this picture, we have everted the eyelid because we have to look below and above where the conjunctiva progresses. Now, acquired melanosis is a spectrum. Could be anything from something that's very benign to a highly predisposition situation where the patient is at significant risk for melanoma, which is a cancer. So this is not an infrequent situation where a patient will be referred to an ocular oncologist with a discussion. Should we watch this? Should we biopsy it? Should we take it out? And if I'm really worried, I will more often lean toward taking it out. But some of the things we look for are similar to try to distinguish whether it was a nevus or not. Is this something that's newly acquired? Is it thickened? Is it flat? Is it have cystic components? And is there previous documentation? And in this sort of situation, you may find someone being more inclined to biopsy than watch. And again, that's sort of it. It takes experience to know that. But certainly if some part of that looks elevated, we may go to surgery at that point. Now, you don't want to, if you can, just cut out a section of this area. You really want to cut out as much as you can for two reasons. You don't want to leave material behind in case it is cancer, and you want to get as much as you can out to the pathologist. But if the area is too wide or too large, it may be too difficult to take it all out without causing some difficulty to the eye and ocular function. If we do see a condition called PAM with moderate or severe atypia, we get worried. If we have an area that turns out to be PAM with no or mild atypia, we're often going to just watch. But if we do remove an area that has moderate or severe atypia, we get very worried about the risk that it could turn into a frank melanoma, a frank cancer, not just a high-risk tumor, but a clear melanoma. And so sometimes what we'll do is we're going to go ahead in those high-risk areas and treat it like it is a tumor. And what does that mean? It usually means resecting as much of it as we can, cutting it out as much of it as we can. It means treating that area with freezing therapy, and it may or may not involve the use of eye drop chemotherapy. And I'll talk about that in the next few slides. Now, the one thing we do get worried about is if this lesion on the surface of the eye turns into a melanoma. And I want you to look at this picture that we've got for you, because one of the things that should stare out to you is this thing is clearly elevated. If I saw this in my office, I would immediately be concerned that this is very likely to be a melanoma. And melanomas in this area need to be treated differently than intraocular or melanomas inside the eye. So first of all, what we will often do in a scenario like this, if a patient presents this way, is first make sure that there are no signs of cancer anywhere else, and that will often involve some imaging, but the imaging will usually involve the head and neck areas. Well, why is that? These cancers, unlike intraocular or uveal melanoma, have a tendency to spread to the adjacent lymph nodes. Now, that's like skin cancer. or skin melanoma that spreads to lymph nodes. And if you look at this picture, you can see this patient with a conjunctival melanoma whose cancer has already spread to the lymph nodes around his jaw. The first key and important thing about this cancer is making sure that you have a surgeon who knows what's called no-touch technique, because the removal of this has to be done in a particular way where we're basically trying to cut this area out completely. And we teach our residents certain techniques, and we go through slides like this where all the techniques they need to do to assess and make sure that the cancer is cut out properly. And the goal here is not to teach you all the surgical components, but really the goal here is to make sure that the area is cut out in one area and one complete excision with what we call a wide margin. So we take out not just the tumor, but a lot of the tissue around it that looks healthy. And we use multiple instruments so that we don't cross-contaminate the cancer area from the non-cancer area. And we'll often use freezing therapy on the surface of the eye to treat anything that's microscopic. Sometimes we'll also do what's called an alcohol epitheliectomy. What is that? Well, basically we scrape the surface of the cornea to remove cancer cells. And the other aspect about this is, and one of the reasons why you really do need to have an ocular oncologist involved, is because getting the tissue to the pathologist and how the pathologist reads it is very important. Part of the surgery here is to make sure that the area is cut out, and cut out such that the pathologist, the doctor who's going to look at this microscopically, knows which side is where. And it's all about the technique to making it just right. Once it's removed, and if you don't have it set properly, it's difficult sometimes for the pathologist to know, was it completely cut out or not? And these are the type of things we do. We show the pathologist basically what's left, right, up, and down, so that the pathologist knows, okay, you've cut this area out, this edge still has cancer on it, but the other edges look fine, or you cut all the cancer out completely. And if it's not done properly in the operating room, it's hard to then know if this is correct or not. Now, as you know from my other talks on melanoma, not all melanomas have pigment. And there is a version of this disease called Amelanotic PAM and Amelanotic Melanoma, or the technical term melanoma sine pigmentum, or melanoma without pigment. And these are very challenging tumors because we oftentimes don't see a mass. And so sometimes in these type of situations, the doctor will go back with the patient and we will randomly do biopsies to see if there's any sign of cancer that's come back. And here again, it's all about physicians understanding the risk and identifying those patients at risk for these scenarios and having appropriate surveillance. Now, this isn't a pleasant picture, and we always try to preserve the eye, but sometimes with this type of melanoma, the tumor just continues to spread on the surface of the eye and the adjacent structures. And when it's really bad, unfortunately, we have to do radical surgery to remove all the tissue, because the conjunctiva starts on the surface of the eye, goes back, and then folds on itself back onto the underside of the eyelid. So it's very difficult to completely remove all that tissue and preserve the eye. And sometimes this is truly devastating to explain to a patient that we have to do something disfiguring, like remove the entire eyeball. And it's not always the best approach that we'd like to have, but sometimes it's the only approach to definitively remove the cancer. And so an exenteration, which is a disfiguring surgery, is sometimes necessary in advanced cases. Now, what about chemotherapy? You usually think about chemotherapy as a pill or an intravenous. You don't think about it as an eye drop, and we don't use eye drop chemotherapy for intraocular melanoma. But for diseases on the surface of the eye, if you have a high-risk predisposing cancer like PAM with severe atypia, or if we've removed your cancer, but we're still worried that there are microscopic cells behind, we may use chemotherapy drops. And the most common drop we use is a drop called mitomycin. It's definitely chemotherapy. It's toxic. It's not always easy to tolerate. You can get red eye. It can be uncomfortable. So while patients are on this drop, we're often going to see these patients closely because we need to monitor the surface, and sometimes we have to lower the dose. Sometimes we have to stop the chemotherapy for a period of time and let it heal. There are some other drops we sometimes use. They're listed on the slide, but the best drop really is mitomycin for this type of cancer. Now, I want to talk a little bit about a technique that a number of patients go through and is offered at Anderson, but it's offered at a number of cancer centers, and that is sentinel lymph node biopsy. And my colleague, Dr. Pete Ismaili, has reported a lot on this technique. We've learned for quite some time that melanomas of this part of the eye, when they get thicker, have a higher possibility of spreading. And again, the spread tends to be the lymph nodes around the eye socket, very different than intraocular melanoma. And so in a technique similar to assessing lymph nodes elsewhere, some doctors will offer what's called a sentinel lymph node biopsy, in particular if your melanoma is very thick, because when your melanoma is thick, you have a higher risk of spread to the lymph nodes. And so what they do in this technique is that they inject a small amount of radioactive tracer around the eye, and then either a head and neck or a general surgeon goes and finds where that tracer is and removes that lymph node. Now that lymph node is then looked at by a pathologist, and if they see melanoma, then you're likely to get what's called a neck dissection. They do a larger surgery in this area over here, and they look at all the lymph nodes that drain this part of the eye. Now, why do they do that? Well, the goal in this situation is to see if the tumor has already started to spread microscopically. And in those scenarios, a patient will be determined to not only have disease of the eye, but outside of the eye. And those are appropriate circumstances to refer the patient to a melanoma oncologist like our own Dr. Sapna Patel. And sometimes additional therapy, immunotherapy, radiation will be offered. And there's still a lot of ongoing work as to whether this improves survival, but it's certainly something that many cancer specialists will offer. And so you should be familiar with this. So I hope this short introduction has sort of helped us, give some hugely different perspectives of what our patients are going through with intraocular melanomas, which are serious. And yes, they are ocular, but conjunctival melanomas are very different. Now remember here as well, experience goes a long way. A lot of times just looking at a lesion on the front surface helps to determine whether it's cancer or not. And sometimes we will have a predisposition to watch, but we will often consider surgery because that will be definitive. And when we do surgery, very important, the technique is critical, and getting it to the right pathologist is critical. Sometimes after therapy, we will give eye drop chemotherapy, and very often the prognosis can be good if we can get to these lesions when they are less thick. It's all about the thickness. It's all about, how advanced the tumor is on the surface of the eye. And if we do have an advanced case, then not infrequently we may need to look for signs of spread, not to the liver, but to the lymph nodes. And that's where the surgical techniques like a lymph node biopsy, a sentinel lymph node biopsy may be offered. So I hope this introduction was helpful. And I encourage all of you in the ocular melanoma community to support your fellow patients, your fellow colleagues. Everyone's going through a different experience. And a lot of times patients with conjunctival tumors have a tough time finding an outlet to find other patients who've had their same experiences, to understand what they're going through, which is very different than the uveal melanoma experience. And of course, we're here to help and answer any questions. I appreciate your time today, and I hope this symposium and I hope these days are really helpful in your cancer journey.